So thank you, Chandra. It's nice to meet all of you, on an evening. So today I will have a sort of a controversial topic, but however has reasonably shown good efficacy. We have seen cabozantinib coming in recently. The generic has been there, cost effective, and has shown excellent efficacy in renal cell carcinoma. So the topic is cabozantinib is the preferred first line in advanced renal cell carcinoma who are not unfit or not affordable for immunotherapy. Next slide. So we have seen the evolution of systemic therapy for metastatic RCC. You can see sunitinib somewhere around 2007, and then we have cabozantinib coming between 2015 and 2017. So this is the evolution. Next slide. So if you look into the ESMO guidelines, you can see that both cabozantinib and sunitinib being there, and the magnitude of clinical benefit scale, that is the NCBS, is around 3 for cabozantinib, specifically being mentioned, especially in the intermediate and poor risk subset. Cabozantinib has got head-to-head comparison with sunitinib and has shown its efficacy. Next slide. So these are the recent NCCN recommendations, where you will see in the preferred regimen, you will see cabozantinib in the poor and intermediate risk in the preferred regimen, whereas in the other recommended regimens, you will see sunitinib. So sunitinib is no longer a preferred regimen either in a good risk or in a poorer intermediate risk. However, cabozantinib still finds its place even in the presence of immunotherapy competitors. Cabozantinib is still a preferred agent in the poor and intermediate risk subset. So this again signifies that cabozantinib has got its place. Okay, next slide. The representation of the similar thing has been there in this slide, where cabozantinib has got its place even in the IO era or IO-TK or IO era. It still has its place in the subset of poor and intermediate risk metastatic RCC. Next slide. So these are the ESMO guidelines and the ESMO recommendations from different physicians, the decision-making analysis among experts in the field of medical oncology, representing 11 centers in various parts of Europe. And you can see that the number of centers that prescribe cabozantinib in the intermediate risk and in the poor risk is substantially higher than sunitinib or pazopanib. So again, this is one more data or an indirect evidence where a greater number of institutes or experts prefer cabozantinib over sunitinib or pazopanib in the intermediate and poor risk subset. Next slide. Next slide. So this is the CABOZANT trial, the trial that has head-to-head comparison of cabozantinib and sunitinib in first-line treatment. And you can see the dosing of 60 milligram versus 50 milligram sunitinib. Next slide. The primary endpoint was PFS, and you can see the study met its primary endpoint with a hazard ratio of 0.48, and the hazard ratio well within unity with a good p-value. And you can see that all the subsets, in the intermediate and poor risk, bone-only disease, MET positive disease, all have benefited cabozantinib over sunitinib. Next slide. So again, the overall survival, even though not statistically significant, numerically it is 26.6 versus 21.2, and the response rates, it's almost triple, 33 versus 12%. So better responses, better overall survival. However, the overall survival cannot be commented where you have subsequent therapies as immunotherapies and they cannot be matched. So that's the reason probably. But if you look into the PFS response rates and also the numerical overall survival, definitely cabozantinib scores over sunitinib. Next slide. So these are the toxicities. Even though the cabozantinib is a wide pan the TKI sort of an inhibitor, Even then, the toxicity is almost comparable to sunitinib. Next slide. So this is the network meta-analysis to include cabozantinib in comparison to standard care first-line treatment for metastatic RCC. Next slide. So if you look into the meta-analysis, PFS was significantly increased for cabozantinib when compared to all treatments in intermediate and poorest subsets. You can see whether you take sunitinib or sorafenib or interferon or bevacizumab, for all comparators, cabozantinib has performed better and it favors cabozantinib, whether it is intermediate or poor risk. Next slide. So this is the overall survival of first-line treatments, and you can see even the overall survival is nominally in favor of cabozantinib in the intermediate and poor risk categories. Next slide. So this is cabozantinib in non-clear cell RCC. Again, the retrospective study, again the evidence suggests that cabozantinib does better even in the non-clear cell subset. Next slide. So this is cabozantinib in patients, with papillary RCC head-to-head comparison. Well, you can see here cabozantinib again does superior to sunitinib or other drugs. So the progression-free survival is impressive, and the overall response rate was 23% versus 4% with sunitinib. Again, signifying the fact that in a chromophobe or a papillary RCC, the non-clear cell RCC, cabo does better than sunitinib. Next slide. So these are the response rates across. You can see the impressive response rates and progression-free survival. Next slide, of different trials. So well, cabozantinib has a mechanism of action that is both anti-angiogenic. It inhibits multiple tyrosine kinases, excellent efficacy and poor and intermediate risk with a tolerable side safety profile. Next slide. So the takeaways are cabozantinib is a TKI with a promising first-line treatment especially in the intermediate and poor risk, and cabozantinib trial has had head-to-head comparison with sunitinib with a superior PFS and a better response rate. It has been a positive trial. It has a manageable toxicity profile. The network meta-analysis again suggesting cabozantinib being superior to sunitinib in intermediate and poor risk. The ESMO MCBS score is better with cabozantinib, and the NCCN guideline still gives cabozantinib as a preferred option in the intermediate poor risk, and cabozantinib also finds a place in the good risk patient as other preferred regimens. So with this, I would conclude my talk, and that will be interesting to listen to Dr. Nandini's talk. Thank you.